Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, and welcome to the latest episode of the POMA Does podcast series, sponsored by the Pennsylvania Osteopathic Medical Association. I'm Dr. Amanda Valia. I am the residency director for the Family Medicine Residency Program in Indiana, Pennsylvania, at the Indiana Regional Medical Center. And I am privileged to be joined by the team of leadership from the proposed IUP College of Osteopathic Medicine, also in Indiana, Pennsylvania. Dr. Rose, perhaps you could start by telling us a little bit about yourself, and then we'll let the rest of your team go ahead forward as well.
Absolutely. So Mika Rose, board certified in psychiatry. I didn't start out in psychiatry, and I didn't start out in my early years in life planning to be a physician. Started my medical training at Touro University in Vallejo, California, in Mare Island. At the time, it was very much a military base that got converted over and is now dramatically changed in the past couple of decades. I did my first year of internship in Oregon, in Corvallis, Oregon, and actually completed my internship here in internal medicine. And somewhere near the end of my internship here, had decided I wanted to switch into psychiatry. From there, I switched into psychiatry and went to Michigan State University, where I completed my residency in psychiatry and also stayed as an attending. I stayed for so long that even when I cut back my hours to work part-time and worked as an assistant dean of clinical education at PNWU in Washington State, I actually stayed in Michigan the entire time, fell in love with the state, and did not leave until I came here, falling in love with Pennsylvania and Indiana. My background is looking at positive psychiatry and a strengths-based approach to mental health. So if you will, an osteopathic approach to mental health and well-being. One of the things I'm really excited about creating here with this brand new state-sponsored osteopathic medical school, which will be, by the way, the first public osteopathic medical school in the state of Pennsylvania, is bringing that approach of positive psychiatry, osteopathic administration and programming and curriculum to a statewide program. So I couldn't be more excited and more thrilled, and hopefully we'll delve into a few more topics about my background. I will just add very briefly, I'm a first-generation physician and a National Health Service Corps scholar. So I had never considered entering a career in medicine. I grew up very poor. I grew up just with not a lot of means around me to give me the understanding or cultural exposure that becoming a physician for myself was possible. I didn't really see a physician or a medical provider as a physician until my later years. And so I had a really interesting journey that I'm hoping will inspire others. And for some of our future generations of students, will inspire them. You know, we can't recruit. We're being very clear. Anything that we say that sounds like come to IUP, we're just encouraging you to enter medicine, not consider IUP just yet. But we really want to look at how can we create cultures of change that really inspire individuals to break ancestral patterns that are not uplifting for their communities and become service leaders within their communities, and looking at the infrastructure, how we can do that. Thank you.
Thank you very much, Dr. Rose. Moving on to Dr. Smith, would you want to tell us a little bit about your background and what brought you here to Indiana, Pennsylvania?
Sure. Thank you, Dr. Neglia. Hi, everybody. I'm Ryan Smith. I'm a psychiatrist, and I'm the Associate Dean of Clinical Affairs here at the proposed IUP, which means I'm overseeing the third and fourth year of the student's education, which is largely done in hospitals and clinics throughout the state and larger region. I came here from Florida. I was the Associate Dean of Preclinical Affairs for the Orlando College of Osteopathic Medicine, which was a new medical school that just opened in Florida. And before that, I was in Maine at the University of New England, where I was department chair of psychiatry there for a number of years, and have also opened residencies in psychiatry. Like Dr. Rose, I'm a psychiatrist, first generation physician, rural background, and am very proud and happy to be here helping develop this program, which is really uniquely rural and really has a major focus in mental health and psychiatry that is integrated throughout the curriculum and throughout the clinical years of education. And I've been very fortunate to interact with a number of our future clinical partners in the 6 or 7 months that I've been here, and look forward to talking more with you all about what we're trying to do here at the new medical school.
Wonderful. Thank you very much, Dr. Smith. We're going to move on to Dr. Mortensen. If you could also tell us a little bit about your background.
Thank you, Dr. Palia. My name is Luke Mortensen. I am the inaugural Associate Dean for Preclinical Clinical Affairs here at the proposed IUP COM. I have enjoyed over 30 years now at this point in medical education, and this will be my 6th medical school participating in research, medical education, and administration. And in between those times, I also was very fortunate to serve as the Vice President of Medical Education at our oversight organization, the American Association of Colleges of Osteopathic Medicine, based in Bethesda, Maryland. But prior to coming here, I was at the Idaho College of Osteopathic Medicine, where I was also part of the inaugural team in developing that brand new medical school for that state, the only medical school in the state of Idaho. And part of its mission and goals was to develop physicians, primary care physicians for the entire state, but also mostly focusing on rural areas, because that state still at this time is 50th in the nation in primary care. But because of that mission and because of the mission developed out for this brand new school here at IUP, I think that is what drew me to this school as their new associate dean. Also, my past professional relationships with Dr. Rose and Dr. Smith, all having that same vision with regard to our job roles in medical education to not only develop physicians for the rural areas here in Pennsylvania, especially rural and underserved, but also drawing potential medical school candidates from those areas. And so that's what I think makes us fairly unique as a new medical school. And so I look forward to talking with you more about that as this interview goes on.
Well, wonderful. And we're going to be talking today about the national rural health shortage, the national crisis in rural health and rural health equity as well. And we're going to be talking a little bit about how osteopathic medicine can uniquely fulfill the needs in the rural communities across our country. And so while we discuss about Pennsylvania and Western Pennsylvania and Indiana County more specifically, we're going through a shortage that is affecting rural communities across the country. So, Dr. Rose, if you could just tell us a little bit about some of the shortages that you've seen and some of the statistics and what we know is happening here in the country and how osteopathic medicine is uniquely set up to fulfill those rural communities.
I will say before I read some of these numbers, as you will know, Dr. Valia, these numbers, if anything, are low estimates because they were taken before COVID, before the Great Resignation in which healthcare was hardest hit, and early retirements as a sequela secondary to all of that. So some of these numbers, although alarming, we suspect are even more dire than are currently documented. And we have asked some folks at the state of Pennsylvania to help update some of those numbers so we can have an even more compelling case statement. So right now, looking at 1,030 anticipated shortage of primary care physicians in Pennsylvania by 2030. Now, for those of you that are POMA members, POMA followers, Pennsylvanians, you can likely see the impact of that. Similarly, primary care physicians, in terms of numbers per capita, an estimated 102.2 primary care physicians per 100,000 Pennsylvania residents. So about 1 per 1,000, about half the national average for rural areas. So in terms of rural aspects, we know that there's quite a bit of challenge across the country. In terms of Pennsylvania rural in comparison to the rest of the country, we are not doing well in terms of our numbers ratios and workforce, frankly, of availability.
Yeah. I was wondering, maybe Dr. Smith or Dr. Mortensen, if you would be able to share with us some of the statistics of particularly primary care and how that relates to osteopathic medicine and the ratios of primary care physicians at our osteopathic schools. We can see on this lovely graphic some of the shortage areas, and much of Pennsylvania is in an underserved area. There are designated areas of both primary care as well as mental health care. Dr. Smith, I believe you had mentioned a little bit about the focus that you want to emphasize through medical education, through that osteopathic medical education, that emphasis on mental health and the reasons why.
Yes. So one of our focuses in our curriculum is a longitudinal course in psychiatry that will be throughout the student's education that will continually reinforce the importance of mental health as it applies to the different systems that the student will be studying. They'll also get a psychiatry course, which is typical in medical school in the second year. And in their third and potentially fourth year, we'll be doing at least 8 weeks of psychiatry, which is twice what's required by the accrediting body and twice what most medical schools require. And that's really to immerse the students in mental health and give them really the full scope of, no matter what specialty they go into, how they can utilize their knowledge of mental health to impact patient care. And I'll just say briefly, I come from Maine, and my first job out of residency was in Washington County, Maine, which is the most uninsured county in all of New England, all of the 6 New England states. And I chose to practice there for that reason and would bring medical students up there. Over the years, I brought over 200 medical students with me to see patients up there over a 6-year period of time. And I was the first psychiatrist that had been up in that county for over 20 years and really saw what the lack of mental health care could do to a community and really to a 2 or 3 county region. We don't expect all or even most of our students to go into psychiatry, but we do expect them all to be proficient in psychiatry and meet the patients where they are and hopefully be comfortable prescribing psychiatric medication, psychotherapy, and other interventions to really meet the needs of rural populations.
Yes, that's wonderful. And Dr. Rose, if you could explain for the listeners a little bit more about the emphasis in osteopathic medicine and meeting the needs of that primary care area.
Yes. So, when leaders of IUP and IRMC got together and started talking about how they could work together to have economic development and support the infrastructure of IRMC, IUP is a university and neighboring institutions that have worked collaboratively together in the allied health professions. They looked at starting a medical school years before any of us on the screen were hired. And one of the things they looked at was an osteopathic versus an allopathic medical institution, knowing that there's a great shortage of physicians throughout Pennsylvania and knowing all of the economic models that a school of medicine likely will have great economic impact on not only this region, but other areas of the state. So looking at osteopathic medicine, all of us as members of this community and profession, statistically, those are twice as likely as their allopathic counterparts to enter healthcare shortage areas, particularly underserved regions. 58% of DOs enter shortage of healthcare professions. We see similar numbers of allopathic clinicians in rural underserved areas. Any of the major national reports will show top of the list, rural regions, medical schools graduating students into rural regions. 5 out of the top 8 out of the top 10 are inevitably osteopathic institutions. And so we know that because of our training, our community, the fundamental tenets and philosophy and approach to osteopathic medicine, that we tend to enter community-based care and we tend to be community-focused and based clinicians, even in hospital medicine. And Dr. Valle, you're sort of the shining beacon example of that. Following of the pillars of tenets of osteopathic medicine, 50% of DOs practice as primary care clinicians. And our counterparts, I think it's even more than double, I think, on the primary care numbers, anything from double to triple that of the allopathic counterparts. And it's not to have any kind of better than or less than for any of the professions. It's simply that because of the tenets and community focus and base of working together and making great impacts on communities, that the primary care and underserved rural focus tends to be a really nice fit with the intrinsic values that are very central to the core of osteopathic medicine and the culture.
Our curriculum will also support a lot of what Dr. Rose has just said, and it's intended to do so. Again, with the focus on rural primary care, if you were able to take a look at some of our curriculum that we've developed out right now, you'll see, as Dr. Ryan Smith mentioned, we do have a lot of longitudinal coursework that will focus on the essentials of rural medical practice. And so what is it that our learners will need to learn to navigate well primary care in rural and underserved areas? And so we'll cover a whole gamut of things, not just medical clinical things, but also things such as the professional and interprofessional manner by which practice can occur and facilitate greater care for our individuals in the rural areas. And so we're very proud of that, because not only will our first 2 years of didactic education cover some of that goal, but also the clinical experiences, the early clinical experiences our learners will engage with will also provide some of that background and support for what they will need when they enter their 3rd and 4th year with Dr. Smith and their electives and their rotations and those experiences that they'll encounter there in support, again, of this ability to facilitate their understanding of what it takes to practice in rural areas of Pennsylvania.
Helping them to understand that rural culture is very important and understand the needs very deeply. We talked a little bit about the primary care and the mental health care, and I know that all of you know, but for the listeners, knowing that in these rural communities, the great need in the area of mental health care is often met by the primary care physicians. So hopefully throughout our state, we're going to be graduating more primary care physicians for our rural areas and some extra psychiatrists as well, but really training all of those physicians right from the beginning to understand that not only do psychiatrists care for the mental health of the communities, but also those primary care physicians who will be going out into these rural regions.
Yeah, Dr. Valia, it reminds me of my first year in training. I was in internal medicine and primary care, and we would have those resident sign-ups, which I know you run many of these. And in my internal medicine clinic, I would see patients in an outpatient basis supervised by an attending when I was a resident, and we would do our little sign-outs where everyone talked about their patients for the day. And the other internal medicine residents would say, well, I saw this patient, he had chest pain, I walked him down to the ED, he had, SD elevation, they're finding all these incredible medical challenges, and they come to my patients, and eventually I developed a reputation. They would say, what was going on with their patient? I was like, well, this patient had extensive trauma, and he was abused and locked up in a room for days and weeks. And people said, what are you saying to your patients? Groundbreaking phenomena. I'm like, well, how are you doing? What's going on? This joke of like these groundbreaking technologies that we'll be teaching with the behavioral health emphasis it's not just taking the time, but it's really kind of creating a mindset and a culture that will be supportive of our students to be able to be efficient. We know efficiency will be incredibly important for our student learners to not be kind of dragging down the already overly heavily weighted attending workloads, but also being able to just have that connection and that power of that pause and taking time to work with patients. When I was an internal medicine resident, 85% of my patients' complaints, challenges, or even primary medical organic causes all came back to a mental health primary concern. So they may have had diabetes, they may have had obesity, they may have had substance use disorders as primary, right? Not even counting substance use disorders at the primary mental health, but they all had sequelae that ended up being depression, anxiety, panic, dysthymia, all different aspects that even if their primary reason for needing to see a physician may not necessarily have been mental health, we weren't going to be able to treat those diagnoses and conditions without being able to address the mental health first. And so we know in this curriculum it's going to be crucial.
And that's wonderful. That leads me back to the roots of osteopathic medicine. And I was wondering if one of you would be able to elaborate a little bit on the body, mind, and spirit approach to osteopathic medicine.
Sure. I can take that, Dr. Valley. This is Dr. Smith. So, from day one, osteopathic medical students learn not only, the basics of medicine in the classroom and so forth, but they also learn the principles of osteopathic principles and practices where they're fostering clinical skills as well, having students examine standardized patients and simulated patients. One hallmark of our curriculum is that we will be doing early clinical experiences where the students will go out into the community in the first 2 years and see actual patients under the direct supervision of a licensed physician. And that, I think, is very important because it gets the students very early experience in simply, number one, how to talk to somebody else, how to elicit a brief history, how to be empathetic, and just pick up on some pearls from those folks that are going to be training them. Rather than waiting until the third year, which is the case at many medical schools, starting students early on with these clinical experiences, I think will help foster that ability to bond with another person and really learn how to communicate in an effective way. I'll just add two other little things. We're also, our clinical sites that we're developing for the third and fourth year of the student's education are all based in rural areas, and the student will be living in that rural area for the duration of their education, meaning they'll become part of the community. Go to the farmer's market, go to the grocery store in town, really immerse themselves in that community in which they're based. The last thing I'll mention is we're also looking to develop graduate medical education. When our students graduate, they have to go somewhere to train in residency. It doesn't just end at the end of medical school. So we're also helping support a number of different hospitals and other entities in either developing new residency spots or helping them augment their current offerings with faculty development, like with Dr. Mortenson's a faculty development expert and has been helping a lot of programs with faculty development, et cetera. So we're really trying to sort of go from the beginning where the student comes from their college or from their hometown, all the way through their graduate medical education, the whole continuum.
Yeah, and Dr. Valia, let me add on to that. I was raised also in a very rural community in central Missouri. I would say more than 25, maybe 30 miles from the nearest hospital. And that hospital was actually one of the first osteopathic hospitals in the nation. And it's where I had my first experience with OMM. I know I'm preaching to the choir here, but, though I'm not a DO, I'm probably one of the greatest advocates there can be out there for the osteopathic profession, being in osteopathic medical education for more than 30 years. There is an amazing gift that osteopaths bring to medicine and to the population, and that is that ability to professionally be able to touch and impart healing through that touch. Our program here at the proposed IUP Comp, will have osteopathic training throughout all 4 years. And within just our first 2 years, we will have laboratory exercises, practicum that the students participate in, where they will receive over 200 hours of direct training in how to professionally and appropriately touch a patient and learn how to impart that healing that comes from training from their OMT. So I'm very happy to say that we're putting that into our curriculum and that our students will bring that with them into the rural areas, which I think is quite important. With our rural population, a lot of them have those physical presentations that are musculoskeletal in nature. And I think this will provide some great service as we send our learners out into the community.
That's wonderful. That brings me to mind that in this day and age of all of our fancy testing and all of the fancy equipment that we have, that I hear Dr. Rose saying that talking to the patient and getting a thorough history, and Dr. Mortensen, you're talking about physical exam and how that's still foundational to caring for our patients.
Yes.
We find that, at least in medicine, since the four of us, I know yourself included, that osteopathic tenets and philosophy and approach is so important that some of the best things that we can do are free with our patient, right? Like just taking a moment to just pause and be with the patient, and the hands-on, our palpatory skills. You know, I remember one attending saying to me, he took a group of students to Africa for one of their missions and some of their work. And the students said, you know, we don't have the medications, the antibiotics. A number of things got delayed and lost in transit. And so, well, what are we going to do? How are we going to help these patients? And he says, you guys, you have like the best tools in the world. We use our hands and treat our patients with manipulation. I see people, and just the idea is that some of the most powerful things are groundbreaking, and they don't have to be these multi-million-dollar innovative technology projects. Osteopathic medicine wasn't really rooted in that, you know, like in the Spanish flu, it was just hands-on and meeting the body where it was at and helping it heal in unconventional ways. And that's the foundation of our entire profession.
Yeah, with that entire philosophy, it's not hard to imagine that we have to be holistic, not only in how we care for our patients or how we train our students to care for our patients, but also in how we entrain our learners how to care for themselves. There will be a significant portion of our curriculum that will be around the topics and the ideology of self-care and mindfulness. And that comes in important, you know, as we look at the past 20 years of statistics with regard to depression and suicidality within the healthcare profession, physicians especially, and medical students. We have to be aware, and we have to provide some training, some feedback, some engagement with our learners on that self-care aspect, so that when they become professionals and go into the community, they can reflect upon that and also utilize that in their care of patients. So that is a very important aspect of our understanding of medical school education. You know, back when we were younger, our educational paradigm did not really include, you know, I'm using these air quotes, soft skills. And I don't know that they're necessarily soft skills, and Dr. Rose can speak to that. These are skills that are paramount in a physician's ability to not only care for their patient, but to care for themselves. So we'll be including that distinctly within our curriculum.
Wonderful. Thank you, Dr. Mortensen. Also, when we talk a little bit about osteopathic manipulative therapy, share with the listeners, in case they aren't as familiar, that training starts when in the medical training process at an osteopathic school.
So from day one, the students are learning the principles and practices of osteopathic manipulative treatment, meaning they're not only in lecture, but they're also in the OMT laboratory with other students and faculty members and practicing techniques and learning techniques on one another by actually doing them to one another. A lot of schools also have student clinics where they might see community members to provide treatment for them as well. But I think a very uniquely osteopathic piece of education where we're learning how to touch other folks in a respectful way, but in a way that's going to give us information and also hopefully, you know, impart treatment on the other person. And the students also will be seeing OMT done in their preceptor clinics when they're going out into the community from the very first weeks of medical school. So I'm very excited to really get that piece off the ground and see the impact that that'll have on our students kind of from day one.
Yeah, it's really being able to feel that treatment and feel the response to the treatment and to be able to heal someone from very early on in their educational process.
Yeah, something we recognize within the profession is that the majority of students who graduate from osteopathic medical school schools, the majority of them will not really engage in OMM, OMT once they get into practice. And it's for various factors, and I think we understand those. But we will be emphasizing that within our curriculum. And hopefully we'll have a larger percentage of our students who are able to maintain those skills. Now, Dr. Smith spoke about faculty development, professional development, which is something that we're also going to be emphasizing that supports our students, because if we have a well-developed and trained faculty who are on the cutting edge of understanding of what medical education is about, especially osteopathic medical education, then I think it's understandable that we'll be bringing out to our community partners faculty development that will include updates on OMM, OMT skills. We'll also be assisting not only our clerkship sites, but our residency sites with updates on OMM and OMT skills, as they, even if they are allopathic physicians, can come up to date in terms of how to evaluate our graduates or our medical students when they're in their clinics.
Yes, that's very important, that faculty development. As a residency program director, I know that it's very appreciated that our osteopathic schools here in our state are very supportive of our educators. And as we expand osteopathic medical education in our state, we will be calling on new folks to be educating. And that step is very important as we are expanding, that those new educators have education themselves and have that faculty development that our osteopathic schools have been very kind to provide as well. I wanted to talk about rural training. You know, it's kind of a newer concept here in this nation to train folks in rural locations. And obviously we have a rural residency program here, and that's been a big part of an expansion from the graduate medical education level to rural medical education. And maybe we could talk a little bit about what benefits learners have and what benefits the communities have from training folks in rural locations.
So thinking about this from the rural perspective is so important because it's part of our mission. And everything that we do has to be obviously informed by our mission, but we are truly a rural-based medical school. We're hoping to recruit students who are largely rural in their own backgrounds, who may have gone to a college in a rural area, who, may not have thought about medical school because of their circumstances or finances or what have you. And we're looking at that population to come here to really hone their skills on campus. And then in their third and fourth year, really immerse them in a rural setting so they really get the feeling for what rural America, rural healthcare is like, both the good and the bad and the challenges. And as someone who practiced in a very rural area on the Canadian border, interestingly, of all the counties in all of New England, it was the number one most uninsured county with almost complete lack of access to care. What you learn to do in rural healthcare, which is a lot of fun, is you really have to be a jack of all trades. I was a psychiatrist, but there were times I'm prescribing antibiotics, I'm prescribing other types of medications because there was nobody else to do it. And that keeps you on your toes. It's really a nice thing to be able to do that, even if you are a specialist, to really kind of have that broad-based approach to medicine. That's one of the things that I think is really fascinating and fun about rural medicine. You really learn to be a jack of all trades. You can't just refer somebody down the hall for a cardiology evaluation for, which medication should I put them on for hypertension. You really have to be able to just kind of roll with the punches kind of on your own. And that's the type of student that we're looking to train. We're looking to train someone that's interested in serving that type of population, but also learning a very broad array of knowledge in order to apply it in settings where you might not have the most current technologies or current diagnostic tools. To me, that's what makes rural medicine a lot of fun.
When we look at some of the statistics and demographics of what rural physicians in practice do have in common with the limited data sets that we have, we see things like a commonality, as Dr. Smith is referencing, of autonomy, a drive towards independence, ability to work on one's own with more limited resources. So there's this element of independence and freedom in a medical care system that every year I'm hearing from more and more physicians, people are feeling more and more constricted regardless of where they're practicing. Similarly, there is an element of rural medicine that tends to feed its own, and really eventually over years and decades, when we talk to other administrators with rural focused models and rural focused medical schools, is that over the years, eventually it creates these inherent natural pipelines. A smaller group and a smaller population, as Ryan's referencing, has more access and portal points in which we can impact and make a difference to students just through the numbers and access points, right? Like many of the rural regions have even healthcare access for families in some of the the more economically challenged and healthcare shortage areas where the practitioners go in mobile vans and they go to the schools. I'm sure you know well about this, Dr. Valia, because there are fewer and easier access portal points because of the smaller populations in the more spread out regions, right? So what that also gives us a unique opportunity and advantage to do is there's less of a barrier to entry for changing culture and changing awareness. If we were to take these models and go into urban centers and try to inspire a future first generation physician workforce stream, if you will, really just talking business, but inspiring students who never would have considered careers as physicians or in medicine. In an urban setting, that's a much harder task when you think about the layers of choice points and media and even just humans that they're exposed to versus these fewer access portal points for points of access and communication overall. That's an easier infrastructure and stronger, frankly, from all of our experiences living in rural regions. It's a stronger and easier infrastructure to access and help collectively change culture, right? We've had conversations with schools. We've had conversations with superintendents. We've had conversations with many community healthcare agencies, and they're all very interrelated, right? Versus large, just population dense regions where changing culture, you may change one culture in one group, but there's so many layers of people. It's really hard to change a group consciousness in that dense of a population and area. Similarly, looking at some of the rural cultural norms, we know that folks who come from rural regions tend to stay or want to stay and return to similar areas, even the instances that they leave. You know, we just met with one of the federal senator's staffers, and he is from a rural region just north and a little bit west of Indiana County. And he talked about, you know what, like, I don't know what would have happened if I had heard about your medical school informing, but I went to school at one of the Pashy state system schools that was just about an hour away from where I lived. I wanted to be close to where I was living, but not that far away. He references Harrisburg as kind of a larger city that he doesn't intend to stay in the long term, meaning in decades now, he likely won't be in quite the big city of Harrisburg, right? Because he describes a cultural understanding of being raised in a rural area. He will eventually want to return to something that is either the same or something like that. And we've seen that time and time again. I can't tell you how many faculty, staff, and administrators we've met at IUP who said, I left, I wanted to kind of leave Indiana and do something different. And they often come back time and time again. So there is even a cultural aspect of even changing that culture that if we can start to tap into that even now and looking at some of the infrastructure of how students are inspired to choose some of those careers, to just drop medicine as an opportunity, just a consideration choice point, it's easier to follow those ripple effects of changing culture and changing group understandings in these communities where they do tend to stay and return to regions that are similar to where they were born and raised. So it's a system that really, in many ways, positively folds into itself and supports itself, that we would love to just become more and more the part of the infrastructure to help inspire students to consider.
That's wonderful. And it sounds as though even students who may not come from a rural background, but bringing them here and teaching them about rural medicine and teaching them how to practice in a rural setting might increase the likelihood that they would stay and practice in a rural area or another rural area nearby.
Absolutely. The statistics are what, and you know these probably better than us, right? Like you were on some of these research study groups and participation of the data collection. Just exposure to a rural medical setting alone for a medical trainee increases the likelihood they will enter rural service at some time in their career by fourfold, just by the exposure alone. And then there's somewhat of a dose response. The amount of time up to a minimum of like 4 to 5 months, they have a greater likelihood to return to practice at some point in time for a certain number of years. I mean, there's some really nice data to demonstrate that.
Those interested in rural primary care shouldn't be afraid of the potential that they're not going to see a variety of clinical presentations in their career if they practice rurally. In fact, that's going to broaden. And I think we understand that a little bit. Even a couple of examples, how broad does our clinical training need to be, particularly in the didactic areas for our future learners? I mean, if you make consideration for what's happening with regard to drugs of abuse and what the primary care physician has to deal with in rural areas. Additionally, I mean, even other topics like pre or post transplant care. When you've got either single or multiple organ transplant, a lot of those individuals live in rural areas. They're needing that care that surrounds that pre and post transplant period of time. And so what are some of those things? And those are things that we'll expand on within our rural curriculum. So the variety of care is definitely going to be within the training of our learners.
Absolutely. Well, I appreciate everyone's time today. We've covered a lot of topics, and I'm sure there are many more that we could cover in future podcasts, but I think we've covered a lot about the importance of osteopathic medicine, the importance of meeting the needs of the rural communities here in Pennsylvania and throughout our nation. And we appreciate all that you're doing to promote rural health and to really invest in rural communities and to really help solve the rural health equity crisis here in our country. I'd like to thank each of you for joining us today. If you have any feedback or episode ideas, please email POMA@POMA.org, and be sure to subscribe to the POMA Does podcast series on your favorite podcast platform or POMA's YouTube channel. We'll see you next time, and stay healthy.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.